So, dear friends and colleagues, it's a pleasure to be part of this ERN webinar and to share a common interest in Coats disease with all of you. So here are my co-authors, Marta Zola, Christina Statopoulos, and of course, Alejandra Daruich. So we are just reminding what is Coats. It's a congenital unilateral peripheral vasculopathy consisting of telangiectasic vessels, ischemic retinopathy, lipidic exudation, which can lead with time to exudative retinal detachment. Now, Coats is characterized by a strong gender-dependent incidence with a male predilection. Incidence is actually unknown. Unless some of you can give me the information, I would be very keen to obtain it. But in my experience, it's extremely rare. I compare it with the incidence of retinoblastoma. Coats is a differential diagnosis of retinoblastoma, and in my experience, it's at least 10 times rarer than retinoblastoma. Now, it is virtually, allegedly at least, always unilateral. Now, there has been recently some reports with the advent of ultra-wide fundus cameras of the presence in the fellow eye of some subtle infraclinical changes in the vasculature. It has even been suggested by use of OCTA that fellow eye of Coats patient display a cryptic foveal phenotype, which can be documented by OCTA with quantitative vascular alterations. So these observations prompted us with Alejandra to study this in more depths by assessing the superficial and deep choroidal plexus vascular density and FAZ by OCTA in affected and fellow eyes of patients with Coats and with an age-matched group of patients. To make a long story short, you have here the superficial choroidal plexus, the deep here. This is the age-matched control, the fellow eye of a Coats patient and the affected eye. So actually, FAZ is enlarged and density is decreased in affected eyes of Coats patients, but there was no difference whatsoever between fellow eye and control eyes, establishing, in our views, the strict unilateral nature of the disease. And this was published last year in Retina. Now, of course, we do have, of course, patients with bilateral signs of Coats. And I present such one case here. It was a patient with a 2B1 presentation in the right eye, pre-treatment on the left and on the right after treatment, extensive treatment in his country of origin. When I saw the patient, I had a careful look on the other eye. And obviously, there was numerous alterations, vascular alterations in the periphery, although the patient was totally asymptomatic in this eye with a normal vision. So he was tested for Coats plus syndromes, and we found that he was a carrier. It was an heterozygote, compound heterozygote carrier of CTC1 mutations. So usually, you know, this is interesting because usually CTC1 patients, they have more this phenotype with a heavy, a very severe phenotype, symmetrical phenotype, whereas our patient had a very asymmetric one. You can also have other syndromes associated with Coats plus disease, the type 1 and type 2 facioscapulohumeral muscular dystrophy, which is one of the most common muscular dystrophy, the third most common dystrophy affecting a human being. Now, we said, I think we can say, we can say that it's always unilateral. It's sporadic, Coats is sporadic and non-hereditary. Also, it is characterized by the extreme variable expressivity, summarized with these 5 stages after Shields and modified by Daruich in 2017, introducing, and she will talk about it a little bit later, with the 2B1 and 2B2 subtypes. Now, what is influencing Coats expressivity? We know that age is influencing the expressivity. Younger age associated with more advanced disease, with a very high, significantly p-value. And the next question we ask is gender. Is expressivity gender dependent? The reason we are asking is that Coats disease is presumably attributed to norrin knockout, somatic norrin knockout, affecting males preferentially, since norrin is a X-linked gene, and females only secondary to a skewed NDP, norrin X inactivation of the wild-type allele. So this presumed underlying mechanism would predict a milder phenotype in females rather than an identical gender-independent expressivity. To go into more depth, we studied our cohort of patients to determine if the clinical presentation of Coats disease was different in terms of age, severity of the disease between males and females. So we addressed the question in the Lausanne cohort of Coats disease, and it's a retrospective study comparing males and females between 1988 and 2021. There was a total of 114 patients in the cohort, including 98 males and 16 females. Very much the proportion that is reported in the literature. But look, the results. If we go to the mean age at diagnosis, there is no difference, basically nothing significant. Nor when we go to examine the first symptoms, no difference at all. And this can be extended also to the severity of the disease. The stage up to 2B2, you see the proportions, they are absolutely the same. 51% of the males are up to 2B2 and 56% of the females. And for the rest of the cohort, you see the proportion is the same. And again, this same observation with no difference regarding the presence or not of a nodule in the 2B stage. Now, in terms of treatment or follow-up, again, no difference. So the conclusion, Coats disease presentation does not differ significantly between genders, despite the fact that it's much rarer in females. Now, the next question, of course, and for future studies, is how to reconcile the theory of NDP inactivation and observation of no gender difference in the expressivity of the disease. To do so, we have to remember something very important that is critical in the understanding and potentially in the deciphering of the mechanism. Just to mention that this was published in BMG Ophthalmology also last year. So we have to remember that the retina of Coats disease is actually a mosaic with the retinal sector with the invalidation of the X gene affected and displaying the phenotype of Coats. So it's by definition a mosaicism, a retinal mosaicism. Now in females, we have to add that the retina, as all other tissues and organs of the females, they are also mosaics as a result of the X inactivation process that takes place early in the development. So basically, if I comment this picture, you have red squares, which are actually retinal island that are Norrin competent because they have inactivated the mutated allele, and you have green islands, Norrin incompetent, because they have inactivated the normal copy of the gene. Now, in females, COATS is the superimposed image of the two mosaicism. To progress, we need an additional hypothesis. And linked to the fact, we think, that Norrin by nature, the Norrin protein, I mean, is a secreted protein. And as a secreted protein, she is possibly able to diffuse, outside the cells that are competent for Norrin. So now the next step, if we admit that we hypothesize a threshold for COATS expressivity, because the inactivation process in the human is, of course, half of the cells, the most frequent configuration is half of the cells are inactivated for the paternal allele and half of the cells for the maternal allele. But it's a Gauss curve, so you can be on one extreme. And we hypothesize a threshold effect of Norrin level, of retinal Norrin level in the female, below which COATS phenotype is expressed in females. So again, I take this picture to illustrate that Norrin competent, the red squares, Norrin competent islands that had inactivated the mutated allele, there is a diffusion of Norrin around this competent island that can rescue the incompetent island that have inactivated the normal allele. So we hypothesize that there's a certain level of Norrin in the retina that is compatible with no phenotype. And if you are below this level of Norrin in the retina, the competent islands here in red, this illustrates the far end of this Gaussian curve on the right. There are too few to rescue the surrounding incompetent islands, and then the phenotype of COATS can express. It's a threshold, a yes-no effect. So of course, this is an hypothesis, but I think this can be verified in future studies. With this, I thank you for your attention. I am ready to take questions or to participate to a discussion.
Thank you, Professor Munier. It's a pleasure to have you here today with us. So let's discuss the classification and management of COATS disease. So Professor Munier already said that it's a rare disease, congenital, usually affecting young males, unilateral, with peripheral telangiectasia, as you can see here in the picture, exudation, and that could progress to exudative retinal detachment in the absence of systemic manifestations. And he introduced also the update that we made to SHIELD classification in 2017 in order to describe a very important point concerning foveal exudation at the macular level. To differentiate two types of macular exudation, the flat macular exudation and the nodular one. We have shown that all patients that present with subfoveal nodule at presentation will develop a macular fibrotic scar, and that despite a very well-conducted treatment. However, patients that present with flat exudation at presentation will progress to macular fibrosis only in 50% of case. So this differentiation is very important at presentation because it is determinant for the prognosis of this patient, and the treatment will not change in this form with nodular or flat exudation. So here you can see in ultrasonography the differences between flat and foveal nodule, and then you can see here an early exudation and angiography and fluorescein angiography with the characteristic of coat disease, telangiectasic vessel and non-perfusion. And then at the right imaging, you can see the fibrotic scar stage with the treatment already performed on this hyperfluorescent scar at the macular level. We have also shown that the subfoveal nodule present with retinal anastomosis in the center. Here I show you the OCT images of a subfoveal nodule at presentation and then at the fibrotic scar stage. So the question here is how to manage coat disease with foveal exudation. And so to answer this question, we have to ask where does the exudation come from? And we know that the main finding of coat disease is peripheral retinal telangiectasia. We know that macular telangiectasia is very rare, presenting in less than 1% of patients. So it is logical to think that the origin of foveal exudation is the peripheral telangiectasia. So the aim of the treatment in early stage of coat disease is to destroy a normal peripheral telangiectasic vessel, to reduce leakage and foveal exudation. And to do that, we will perform direct laser photocoagulation of telangiectasias with large spot and long duration. And we will evaluate response of the treatment at 3-month interval. So here I show you an example of coat disease with foveal exudation, peripheral telangiectasic vessel, and you can see here the plan from laser spot treatment. So we have said that foveal exudation in coat disease comes from telangiectasia, and that direct laser photocoagulation could allow the resolution of the exudation. So the next question is, do anti-VEGF have a role in the management of coat disease? And it has been shown that VEGF concentration is increased in the subfoveal fluid of patients with stage 3 coat disease versus rhegmatogenous retinal detachment. Also, aqueous VEGF concentration is increased in eyes with stage 3, A2, and 3B coat disease. So it seems logical to think that an anti-VEGF treatment could be beneficial from stage 3, A2 coat disease. And indeed, several papers have been published on the topic using anti-VEGF treatment as adjuvant to laser therapy. However, most of these studies have no control group. There is one retrospective study that compares a laser with or without anti-VEGF in patients with matched, who were matched by macular appearance, and the authors show higher success rate in the group using anti-VEGF. However, one point that remains controversial is the higher risk of vitreoretinal fibrosis and tractional retinal detachment when using anti-VEGF in coat disease. So last question is, do sleep posture have a role in the management of coat disease? And there is a very recent paper published last year that suggests that advise patients to adopt a sleep position during treatment accordingly to the exudation will be beneficial to reduce foveal exudation. Finally, for more advanced stages of cold disease, like with a total retinal detachment, the aim of the treatment is eye preservation with attached retina, and photocoagulation laser need to be associated to other therapies as external drainage, as I'm showing you in this video, to drainage the subfoveal fluid and allow better photocoagulation of telangiectasia, but also vitrectomy or anti-VEGF. So in practice, I will say that direct laser photocoagulation of peripheral telangiectasia is the most appropriate treatment option to manage foveal exudation, that anti-VEGF therapy indication is further evaluation but could be considered as an adjuvant therapy, and that when extended retinal detachment is present, additional treatment modalities should be associated. Thank you for your attention.
Okay, so my presentation is like ups and downs. I always want to say ups and downs in cold disease management. Of course, it's a rare disease. We usually have about 1 patient in 2 years. And of course, this is not a huge experience, but we all try to do the best, and I'll try shortly present our experience and attitude towards cold disease. So despite the fact that George Coles described the disease at the beginning of the last century, this entity still causes a lot of challenges. And it's interesting that the classification that we use was proposed almost 100 years later. And we believe that staging is indeed very important, because it's important not just for the stage, but it has a prognostic value and it defines treatment strategy. So Shields in his original classification also proposed some percent for the pre-visual outcome. And we'll come back to this slide, I think, at the end of the presentation. Yeah, so staging is one important moment. The other important moment is differential diagnosis. And we must do, of course, all the tests that are possible, and we should differentiate from other disease, like, of course, retinoblastoma, toxocariasis, hemangiomas, ROP, retinitis pigmentosa, familial exudative vitreoretinopathy, and other disease. And I've included a couple of slides that are our patients. One, the upper one picture is of the boy who lost his eye when he was, one of his eyes when he was 3 years age, but we know nothing about that. He came to our hospital when he was 16 with a retinal eye like this. And in the beginning, we thought that it's a cold disease, but later, looking at the vessel, decided that this is familial exudative vitreoretinopathy. Actually, he was treated, operated, and we preserved vision in his eye. The other picture includes a case of retinoblastoma. Actually, this was a patient, 6-year-old girl, who presented with lost vision in one eye, and we were sure that this is a cold disease because she was 6 years old, and we thought that retinoblastoma should be a bit earlier, at least up to 5 years old. So okay, but the literature is described. And unfortunately, the real diagnosis was found out when the eye was enucleated. So yeah, differential diagnosis is really, really important, and is still a challenge. So talking about treatment, so the primary purpose, of course, is to preserve macular function by minimizing macular edema and lipid exudation that can cause permanent damage of the fovea. And the secondary, or maybe sometimes the primary purpose, is eye globe salvage. It is just to preserve eye globe. And we have options of observation, of laser therapy, of cryotherapy, intravitreal anti-VEGF, intravitreal steroids, which actually I will not talk a lot because we don't use them, as I believe that in pediatric patients, because of cataract formation, they are, okay, they might be used, but we need to be very careful with that. Of course, surgical treatment, enucleation, and on the other hand, we should never forget amblyopia treatment to preserve function. So for the observation, I'd like to present one quite anecdotal case. It was a girl, a female patient, and she was 3 years old. She presented with a decreased visual acuity in one eye, and we diagnosed Coast disease, and actually her parents disagreed to treat her. They thought that it would only worsen the situation. It was like such a belief, and we decided just to observe her. And what is interesting that after 3 years, we noticed a spontaneous regression of the disease. As you can see in the pictures, the first picture is done when she presented, and the picture on the right, it says when she, after 3 years. And actually, she was stable for 4 years. And after that, actually, vitreous fibrosis has developed, and her visual acuity decreased. And actually, she was further referred for surgery. And then we preserved retina and eye globe, but visual function slightly increased, but remained quite poor. So, of course, it's not an option to observe. Just I wanted to show the spontaneous regression case. And usually we think that observation should be for the patient in stage 1. It's when it's just retinal telangiectasia or telangiectasia with exudation, but when exudation is not vision threatening. And I included the picture of our patient. He was treated. And sometime after the treatment, we noticed that there is another new telangiectasia and very mild exudation. However, in this condition, he remained for about 3 years, and the exudations remained like we see in the picture. So we decided not to treat him additionally, and we just keep observing him. Cryo laser, of course, it goes to obliterate pathologic vessels, and cryo actually we use quite a lot because laser we got quite recently, and we use it for peripheral telangiectasia with exudation and retinal detachment. Actually, we use triple free thaw method, and usually we keep it for a long time, especially if it's a retinal detachment, exudative retinal detachment. I believe that with pediatric patient, we need to freeze retina really strong, a lot, and much more than for adult patients. And according to literature, this might increase the peripheral membrane formation and traction. And laser, of course, is the most popular choice of treatment, and in most cases requires repetitive sessions. And it's possible to use green or yellow laser just to close the vessels. And actually, we use also diode laser for surrounding retinal coagulation, and we believe that if we create like a barrier surrounding telangiectatic vessels, these scars alleviate the drainage of the fluid. And even if we do not occlude completely vessels, there are a lot of chances that exudation will remain local. And I'd like to present one patient that was not injected, was treated just with cryo laser. He was lately presented case, 12 years old, visual acuity was preserved, actually found accidentally. And we treated just with laser and cryo. After 6 years, he was stable. After 11 years, he was still stable, and visual acuity remains good. So it's in this case, we believe it was quite appropriate treatment. Anti-VEGF, of course, they are described that they impressively reduce intraocular VEGF concentration, reduce vascular hypermobility, decrease retinal exudation, promote resolution of subretinal fluid. There are some warnings about vitreous fibrosis leading to tractional retinal detachment, and we have one case by Alejandra and Francis about successful treatment of advanced stages 3B and 4, even without surgical treatment. And in literature, it's now quite described that its combined treatment with laser cryo is effective in Coast disease with exudative retinal detachment. I'd like to present one article, one publication. It's about analysis of pooled result of Coast disease. The authors analyzed 175 articles, more than 1,000 eyes, and the aim was to elucidate the association of treatment modality to vitreous fibrosis and tractional retinal detachment. And actually, they found that the main risk factor for vitreoretinal fibrosis or tractional retinal detachment, it was pre-treatment fibrosis. And laser was not much associated with these complications, cryotherapy a little bit. However, when they look at combined treatment, anti-VEGF combined with cryotherapy, that showed a significantly higher risk for tractional retinal detachment. However, laser with anti-VEGF continued to be protective from vitreoretinal fibrosis. So, according to authors, it would be better to use laser and VEGF than cryo and then VEGF. Actually, this patient we treated just before we read the surgical, so we combined all kinds of treatment with laser, cryo, and intravitreal injections. And despite the fact that we did not use green laser and we did not include all the vessels, however, cryotherapy was sufficient, and as you can see that within 1 year, macular star resolved. And in fact, patients remained stable. About 3 years after the last treatment, we found foveal cyst, which actually was very responsive to nepafenac treatment, usually applying drops for 2 or 3 months. It reduced, and when we stopped treatment, it reappeared again. However, after 7 years, he remained stable. We can see just a very slight retinal edema, macular edema. He was not treated additionally, despite the fact, as we can see, there are still some active telangiectasias and some exudation. But because his visual acuity remained stable for all the last years, he best corrected visual acuities 4 lines. So we decided just to follow up and to treat if only visual acuity will decrease. Of course, if we have case with foveal and nodule, it goes to macular fibrosis, and of course visual results are quite poor. This patient was treated at the age of 1.5 year, and we applied 3 injections on laser and cryo and periphery. And 5 years later, we have anatomically good results, but functionally, what's corrected visual acuity is just 1 meter. And before proceeding with surgical treatment, just to say that actually now intravitreal injection of anti-VEGF is our choice of treatment. Actually, we believe that if patient comes with intraretinal or subretinal exudation, first of all, we would inject him at least 3 times, and only then to proceed with laser and cryo. Surgical treatment we apply for postplanar vitrectomy and extraocular drainage, and also to present one article, one publication, quite recent. Author compared postplanar vitrectomy with extraretinal drainage with cases without extraretinal drainage, and they found that anatomical effect is way better when we apply extraretinal drainage. However, it's not related to functional outcome, and it is more related to age and initial best corrected visual acuity. And this is our one of the most unsuccessful cases. It was 8 years boy who applied to our hospital with visual acuity, just light perception. We injected him 3 times. In fact, retinal detachment just increased. Then we referred him for the postplanar vitrectomy. Got phaco, intraocular lens, external drainage, cryo, gas, and maybe we overdone a little bit. We've got extreme inflammation, very severe reaction, which caused ciliary and total retinal detachment, which further programs to phthisis of oculus bulbi. So our now local recommendations, like a guideline. It's for the stage 1, we use just observation laser. For stage 2A, anti-VEGF, laser cryo. 2B, it's anti-VEGF, laser cryo. Stage 3 and 4, we would apply for drainage, laser cryo. Most probably at the beginning, we would inject for 2 or 3 times. And of course, for the stage 5, just observation. And the principles that we try to follow that less is more. It means that we shouldn't overdo the surgeries. And the second point is, of course, this long-term follow-up. And talking about outcomes, we should go back to the first initial slide about the classification and staging of the disease. We know that onset at younger age is related with four special outcome, and advanced stage representation, diffuse involvement, cataract, vitreous retinal fibrosis, vitreous hemorrhage, fractional combined retinal detachment. They all lead to they are all poor prognostic factors. And subfoveal glottic nodule and lack of visual rehabilitation is actually appropriate treatment. They suggest poor functional outcome. So that's in short from our side. Thank you for your attention.
Good afternoon. First of all, thank you for the invitation to participate in this interesting webinar of cold disease. We want to talk about the importance of early treatment and early referral to improve the final prognosis of this disease. We are going to present two case reports. The next slide, please. First, as a brief reminder of cold disease, it's an unilateral and vascular disease characterized by the presence of retinal telangiectasias and aneurysm with progressive retinal exudation that progress to produce a non-rheumatogenic retinal detachment. It is not associated with systemic disease and is more predominant in young males. And the next, please. We begin with the first case report. It's a 5-month-old baby who is referred for evaluation due to leukocoria in the right eye. He has no medical history, and in the eye fundus, complete exudation with macular involvement and superosseous retinal detachment can be seen. It's a stage 3A1. Telangiectasias can be seen in the temporal and inferior periphery, not visible in the photo. Early treatment with laser and bevacizumab injection was decided. The next, please. The patient is explored and treated in the operator room approximately every 2 months. The photos show the slow positive evolution of the disease until the final photo. The next, please. We can see that exudation remains better and the superior retinal detachment. The next, please, is more less with less exudation. The next, please. And the next is the evolution in the retinography. 2 years of treatment with 5 laser sessions, 2 sessions cryotherapy, and 10 bevacizumab injection. 10 injections of bevacizumab were necessary until the disease reached remission. In the last examination, the next, please. The visual acuity was 400, no 800, sorry, it's a mistake, with no telangiectasia, no exudation, and retinal scars. The disease actually is inactive. And this case is a good example of when the disease could be controlled due to an early treatment.
So I'm bringing case number 2. Thank you so much for the invitation to talk today. And case number 2 did not respond as well as case number 1. This was a 12-year-old male who was referred to our hospital from another city because he complained about worsening of visual acuity in his right eye for 3 to 4 weeks. He got in this other city annual eye exams for an untreated retinal vascular anomaly diagnosed when he was 6 years old. So the first time we saw him, he had a mild hemovitreous that is pointed with the red arrow. He had nasal and inferior retinal detachment. And here with the blue arrow, I have better pictures after. He had a very thick vascular lesion that was surrounded by a lot of fluid. So we diagnosed him of Coats disease stage 3A2. The other eye was totally unremarkable. And we scheduled him 1 week later for an examination under general anesthesia, trying to give him cryo or extraocular treatments. But the hemovitreous got worse and blurred completely the exploration. So we gave him weekly eye exams with fundoscopy and echography, and the hemovitreous didn't clear by itself. So 4 weeks after, we performed vitrectomy, 25 Gs vitrectomy, with additional cryotherapy to treat the inferior vascular lesion and an anti-VEGF injection. This is the retinography after and before and after the vitrectomy. So the plan was to give him repeated examinations on the general anesthesia plus focal treatments, but he started to have a tractional component of his retinal detachment. Here you can see with the red arrow the inferior retinal vascular lesion that was very thick and very elevated, so it was very difficult to reach with cryotherapy. And we gave him the first month after vitrectomy, we gave him cryotherapy and Avastin injection. The third month, we gave him cryotherapy, more extensive cryotherapy, and we decided this time not to give him anti-VEGF, trying to reduce the risk of increased traction. And instead, we gave him a transeptal triamcinolone injection. And then in the fourth month, we gave him an Eylea injection. But we saw that the traction was getting worse. As you can see in these retinographies, this was at the beginning, and then as you can see, he got a very important tractional component in the nasal and the inferior retina. So we decided to perform a new vitrectomy, this time with peeling with bimanual technique, peeling all the epiretinal membranes. The retina relaxed very well. We had to use a chandelier accessory light, and we achieved retinal reapplication with perfluorocarbon. During the peeling maneuvers, we had a very little peripheral retinal dialysis that was not intended, but allowed us to drain the subretinal fluid, and we could give him complete endolaser to all the vascular lesions, even the very thick inferior one that we believe that got a little smaller because of previous cryotherapy treatments. Since we had this peripheral retinal dialysis, we left silicone oil as tamponade and gave him a transeptal triamcinolone injection to reduce inflammation. This is the retinography after vitrectomy. As you can see, the traction is gone and the retina is totally attached, and the exudation starts to decrease. So what we think happened in this case? First of all, the inferior vascular lesion was very thick and elevated and was very difficult to treat with cryotherapy. Second, we believe anti-VEGF injections increased vitreoretinal traction, and also we brought this case because we believe that it's very important to do an early referral of these patients, because if the other hospital had sent him when he was 6 and only had a telangiectasia, the treatment would be very easy. Instead, now he has to surgery, and treatment is more difficult. So in our hospital, our approach depends on the stage, as you said before. For stage 1, we do laser. For stage 2 to stage 3A2, we do laser and cryo. For stage 3B, we try cryotherapy, but if it doesn't work, we do surgery. For stage 4, we would enucleate if the patient has pain, but luckily we don't have any patients in this stage. And then for stage 5, we do observation and external confirmation if needed. Also, we do transeptal triamcinolone after the first treatment to reduce inflammation by cryo. Also, we give anti-VEGF injection if we have subretinal fluid associated, because we believe it helps to reduce the fluid a little bit faster than if we don't use it. Also, we know that we have to be very careful if we do extensive cryotherapy plus anti-VEGF injection because of the increased risk of traction. And we have angiography now, but we only use it if we have doubt of where the patient or which lesion are leaking, but usually we don't do it in all patients. And we only use silicone oil as tamponade if we have a retinal brace. We see these patients at first every month or 2 months. Then when we think it's starting to get control, we do it every 3 months, because this gives time to exudation to improve. These explorations are made in the operating room. After we have total control of the disease, we do optics exams after 3 months, and we do refraction, also amblyopia treatment. And then we do live revisions every 6 months, because there is an 8% risk of reactivations. I want to thank all our team in the pediatrics department, because we're very lucky to work with all of them and to complete our retina section.
And we have Professor Özdek that finally made it. Are you here, Professor Özdek?
Hi, I would like to, thank you. I really would like to talk about the surgical treatment, because we have some real discussion topics like, in the early period, when we see very severe disease in the early childhood, it's usually like total exudative retinal detachment during the first 3 years. And in those eyes, you need to do a surgical treatment. Usually laser is not enough, and you can't do the laser in highly bullous detached retinal detachment. In such cases, I usually do the external drainage first and do the ablative treatments afterwards with anti-VEGFs, combined with anti-VEGFs. But I was doing like that in the early years, but I just noticed that these eyes usually developed some periretinal membranes, some tractional component of the retinal detachment. In addition to this, they also have much more. They need much more additional treatments during follow-up years. So I turned to do combined vitrectomy in these eyes. The retina is usually at the back of the lens, very severe advanced disease, and you do external drainage, and the retina goes backwards, and then you enter the eye through the pars plana, and then do vitrectomy. And when you just take that vitreous, which is, probably full of VEGF and, all the fibrotic things, and you just take the vitreous out. You don't have to do extensive surgery, but if it is possible, it will be good if you can do the posterior hyaloid detachment. That would work perfectly. But if you can't, you don't have to do that. You just take the vitreous by the out, and then do the laser directly to all of those dilated vessels, in addition to telangiectatic vessels. Do the direct laser to those leaking vessels, and then you can also do some cryo to the ischemic, avascular retina in the periphery. You can see that usually, and then I just leave the eye in air and put anti-VEGF at the end of the surgery. This is what I do. And then during follow-up, and you do this kind of surgery, during follow-up, it's usually very quiet. I could just catch the last part of your discussion that we don't know the cause of recurrences and things like that. We have just compared our surgeries, which are combined with vitrectomy, and those which are just external drainage and just ablative surgery. We have seen that when you combine vitrectomy to these surgeries, then you have much less additional tech treatments like laser, anti-VEGF. The need for additional treatment decrease a lot after combining vitrectomy. And we have already published this in American Journal of Ophthalmology 2 years before, and there was significant difference in between the vitrectomy and non-vitrectomy eyes. So our routine approach in severe bullous retinal detachment eyes is to do ablative surgery together with external drainage and vitrectomy, not only with only external drainage.
Okay, and that is your approach from 3B, from the stage 3B, or even before?
3A and 3B.
Okay, so partial retinal detachment.
And also some, we have some stage 4 eyes too.
Okay, great. Thank you to share with us your experience. We can finish our webinar. I thank all the presenters for your intervention. I thank the ERN-EYE web team for the organization of the webinar, Caroline, and all the people. And I thank you for your presence here today.